Okay, I'm Dr. Weiss and from New York Orthopedics, one of the non-surgical sport medicine doctors. And today I'm going to discuss how to do ultrasound guided knee and shoulder injections. And this is really tailored for primary care physicians. And I hope you find this talk worthwhile. Really, the most common injections that we do in the office are probably the knee injection. I would say by far the knee injection, and then the shoulder injection, the subacromial injection, is probably the next most common injection. And if you can really get a good sense how to do those two injections, you really will probably cover 90% or 95% of the injections that you're going to do in the office. And that even holds true, I think, in an orthopedic office as well. So as a primary care doctor, again, you really just need to learn a handful of procedures and you can really be quite busy just with those two injections. So today we're just going to focus really on some basic principles of musculoskeletal ultrasound, and we're going to cover, again, doing the suprapatellar approach for the knee joint injection using ultrasound and subacromial injection. And we'll try to go into a little bit of glenohumeral injection for the shoulder, which is not as common and it's a little trickier, but we can certainly go through that as well. So advantages of ultrasound are that compared to other imaging modalities such as MRI or CAT scan, it's obviously much cheaper. It's point of care. You can do it right then and there in the office visit. It's very convenient, and what really makes it unique is that ultrasound is dynamic. So you can actually move the body part and see it in real time, how the tissue planes move and glide over each other. You really can't do that with any other modality. If someone has a prosthetic joint, it's excellent for imaging the tissues superficial to that joint. You can use it in pregnancy, and besides being diagnostic, it's also interventional. Some of the disadvantages of ultrasound is that the sound beams cannot penetrate bones, so anything underneath a bone or underneath a metal prosthesis you will not be able to visualize. And another disadvantage of ultrasound is that it's really not only dependent on the skill of the technician, it's also dependent on the patient itself, or him or herself. So essentially, your younger, thinner patients, you're going to get a better image versus people that are larger and older. Unfortunately, the image quality is not as good. The distinction between the different tissue planes are not as apparent in an older and overweight patient. So those things can make ultrasound challenging. And again, a lot of the ultrasound image quality and even interpreting the image quality or interpreting the images really depends on the technician doing it. So in the beginning, ultrasound can look kind of like a snowstorm or a blizzard where you can't really make out the trees from the road, and things are very hard to decipher. But as you get more accustomed to ultrasound and looking at ultrasound images, then things become much clearer and you can distinguish structures much more easily. So particularly orthopedic surgeons that maybe have 2 or 3 days in the office, they're kind of limited amount of time they have with patients and they don't want something else to slow them down. So that's one of the concerns. But I would say, if you get yourself and your medical assistants and your staff used to ultrasound, it really won't slow you down and you really won't want to inject without it. Some ultrasound basics: when you're holding the probe, you want to move it slowly, because especially when you're trying to find a needle which is only a millimeter thick or so, and you want to be very deliberate in your motion. Another thing which I can't emphasize enough is really to know your anatomy, because if you don't know your anatomy, looking at an ultrasound image is going to be quite confusing. So different terminology that we discuss with ultrasound is basically how bright or dark something is on the screen. So if something is very bright or white, we call that hyperechoic. If something is black, we call that anechoic. If something is in between, we call it hypoechoic, and everything is really relative to something else. So something like the median nerve, for instance, in the wrist, it can be hypoechoic in the wrist, but as you move up in the forearm relative to muscle, which is very dark, the nerve actually appears hyperechoic or bright. So everything is really relative to something else. If something is isoechoic, it means it's the same grayscale as another structure. And then we use different terminology to describe texture of something. So a tendon or a ligament is described as fibular. A nerve is described as a honeycomb type texture or a starry night texture. As you go through ultrasound, get used to seeing nerves versus tendons. The difference will be quite apparent. And there are different probes that we use. There's a high frequency probe or a linear probe, which is probably the most common probe you use for like 99% of the time. There's a low frequency of curved linear probe, which you only really need it for very deep injections or in patients that are very large, where you need to get deep. The advantage of the high frequency probe is that you can have very good resolution of structures, but the disadvantage is that it really can't penetrate very deep. A low frequency probe, the advantage is, again, it can go deep, but you lose that resolution. And then there are different artifacts. So we talked about ultrasound waves cannot penetrate bone or metal. So there's a shadowing artifact under, let's say, bone. If you insert your needle in a patient, you'll see what's called a reverberation artifact, where you'll see many needles underneath the actual needle. And there's refraction shadowing. For instance, when you get torn tendon stumps, you may get shadowing underneath those stumps. And then you can get increased signal through torn structures as well, called through transmission. And then we describe short access or long access. So short access is described as a cross-sectional view of, let's say, tendons, where you're looking at the tendon in cross-section, essentially perpendicular to the fibers, whereas long access, you're looking at a tendon in line with the fibers. And then it's important to label your images so that someone else that didn't do the study can kind of figure out what's what and orientate themselves. So I usually like to label my images the way that I look at an MRI. So I like to say whether it's axial, sagittal, coronal, and then I label medial, lateral, distal, proximal. Sometimes I'll label cephalad or chordal, and sometimes I'll do a combination of labels if it's like proximal and medial or cephalad and medial, just to really be as exact as possible. And usually when I place the probe on the patient, I usually like to have the probe move in the direction on the screen the same way I'm moving the probe on the patient. So again, for primary care doctors, ultrasound is a great way to make your practice more colorful, induce procedures. And again, I'm sure you see a ton of knee arthritis and shoulder bursitis or impingement type symptoms, and you don't really need to refer these out. You can really just learn a couple of few procedures yourself, and you can kind of keep these for yourself. So let's go over the knee injection. So here we're looking at a knee. This is actually the quadriceps tendon in long access. Here's the quadriceps fat pad. Here's the patella. This is the femur, prefemoral fat pad. And this anechoic dark signal is actually the knee joint fluid. And it's discussed when the knee is bent maybe 30 degrees, you get a little bit more concentration of fluid in the suprapatellar pouch versus the actual gutter, which you can see here. Here, again, we're looking at those same structures with the knee extended, quad tendon, and here's the gutter where the fluid may congregate when you extend your knee. Here's an interesting case that I saw early on in my career. So this is just comparing what an MRI looks like in terms of synovitis, and here is actual ultrasound synovitis. Here's that black anechoic fluid, and here is actually the synovitis on arthroscopy. So you can see how it all correlates nicely. So suprapatellar approach for injection has advantages over the typical anterior approach. One thing, when you're injecting anterior, meaning just under the patella, and you're going medial lateral to the patella tendon, just underneath, again, the patella, if you go too far, if you don't angle it quite right, you may actually go right into the condyle, potentially injuring the hyaline cartilage. And when you do a suprapatellar approach, really you're just going to hit bone if you go too far in, which won't injure the patient in the long run. You can also aspirate suprapatellar and inject at the same time. And also, the patients are lying down, which is just always better to inject or do any procedure when they're supine in case they get vasovagal. Regarding aspiration, you always want to make sure you use a large needle, such as an 18-gauge needle. You're not helping the patient by using a smaller needle, which easily gets clogged and will take quite a long time to aspirate. So it's actually probably more painful to use, let's say, a 25 or even a 22-gauge needle, which again can get clogged and will take you a lot longer to aspirate fluid. Always make sure you want to use a needle that's long enough. So here we're doing viscosupplementation. These are 2.5-inch needles. Always better be on the side of having a longer needle versus a shorter needle. And here, this is a little bit misrepresented because when you attach these needles, these are spinal needles, you want to keep the stylet in. So keep the stylet in, insert the needle, then unscrew it, and then put on your injectate after you take out the stylet, obviously. And you need to keep that stylet in so it can cut through the tissue better. So let's go over a knee injection. Here's a patient. We're doing a platelet-rich plasma injection for knee arthritis. You can see here in this left knee, there's basically moderate arthritic changes, primarily of the medial compartment. Here we're just going to go through some of the anatomy. So here you can see the iliotibial band. Here's the patella. Here are the quad muscles. Essentially, when you do an injection, I feel that superior lateral patella, patient's lying supine, and then I go about 1 centimeter or 2 cephalad, and then I go posterior, and I feel that anterior margin of the iliotibial band. And then I put my needle just above that anterior margin. I usually aim it a little bit caudal and a little bit up. So I'm basically trying to get the needle right over this prefemoral fat pad, which you can see here. Here's this little quadriceps fat pad, and that's just near the patella, so that's usually not in the picture. It's usually just trying to get your needle just above that prefemoral fat pad. So this is what we call an in-plane approach, where the needle is basically parallel to the probe, and here is that needle just above that prefemoral fat pad. So what does this look like on ultrasound? This is actually an iodine swab. I usually use that to push on the skin to get a good sense and kind of extrapolate where I think that needle is going to head based on just some pressure with that iodine swab. Again, it's a pretty hard and pretty small diameter structure, so you can get a fairly good sense where you're going to head. You really want to see the tissue planes of that quad tendon gliding over the prefemoral fat pad. Here's a long axis view of that quad tendon, quadriceps fat pad, prefemoral fat pad. He really doesn't have much of an effusion. So here we are, we're starting with the injection. You can see my needle is actually angled up. I'm in line with the probe, or this is an in-plane approach. Here's the needle coming in, and I'm just trying to get that tip above that prefemoral fat pad. And here we are. You can feel it usually pop through. We're in this little sliver here. This is all part of the quadriceps tendon, and the quad tendon is not very distinct because, again, there's 4 muscles that feed into it. You're basically just trying to get your needle tip right above that prefemoral fat pad, and that's really all there is to it. I just want to go back. So this is really the key of doing the knee injection, is that you're pushing on the skin again with a swab. You can even do it with your finger, and you see this prefemoral fat pad gliding under the quad tendon, and that's how you're going to kind of decipher these 2 tissue planes right in here. And that's really the trick to this injection, because there's really no space. It's just a tiny little sliver of fluid, and you're trying to get your needle here. And another thing, we just showed those orange highlighted areas, the prefemoral fat pad, and that's just actually the fat pad. That's not joint space. Even though it looks dark and black, similar to the joint space, you don't want to be fooled and put your needle actually within the prefemoral fat pad itself. Another pearl is that if it's really painful when you inject the patient, that means you're probably in the fat pad, so you should readjust your needle. And when you're injecting something like, or really anything, even cortisone, or especially something very expensive like PRP, you're probably best off going in with saline initially, confirming that you're in the right place, and then unscrewing the saline and putting on the actual injection. Here's another couple of cases. It's good to see different cases. So here again, the needle's coming in from lateral to medial. Here's that prefemoral fat pad, and here is part of the quadriceps tendon. And here we are, we're injecting, and as you inject, you can see black anechoic fluid surrounding that needle tip. It actually gets easier to see the needle tip as you inject. And here you can see basically the quadriceps tendon. Here's this prefemoral fat pad, and we just got our needle tip right in between the quad tendon and the prefemoral fat pad. Prefemoral fat pad, that needle tip, you can see this injectate. You can see it trickle down, and you can see it kind of contour that prefemoral fat pad. I call this a contour sign when you get bright, hyperechoic, basically air from the injectate contouring different structures, and it's forming a nice contour sign over that prefemoral fat pad. I'm going to go over aspiration. Now, if someone has a large effusion, you don't really need necessarily ultrasound to tap that knee. But even in those that have a very large effusion, if you really want to get like 90-95% of fluid out, or maybe even more, then I think ultrasound comes in handy, and I'll explain why. So here's a patient. He has obviously severe lateral compartment arthritis of the knee, and you can see on this lateral x-ray all this fluid. This is the prefemoral fat pad. Here's that quadriceps fat pad. You don't see that posterior margin of the quad tendon, and that's how you can basically diagnose this effusion on x-ray. All this black is fluid. We're looking at the quad tendon in long axis, or in an anterior sagittal plane. Now we went to an axial plane, but you don't even see the femur. He has this ocean of fluid essentially. So you don't need ultrasound to get into this, but these 2 tissue planes are going to converge on each other. So the prefemoral fat pad is going to converge on that quadriceps tendon. And then if your needle is over here, you may think you're done, but you have all this fluid on the other side. So that's why ultrasound is so handy, because you can still see that you have a lot of fluid remaining. And if you have someone to help push on the medial side of the knee, look how much that space opens up. It's almost like you're starting from scratch again. And you can get, again, I think we got 180 cc's or something like that out of this patient, a lot of fluid. So here it looks like we're done, but if I have someone push on the medial, these are mislabeled, this should be medial, then you can see how much that opens up the space. So this really comes in handy. Here you can see the synovitis, prefemoral fat pad. Here's the needle, a little bit of a reverberation artifact. And when someone pushes, they can really open that space up 100% or more based on how much fluid remains. So the push technique, if you have an assistant, if you're lucky enough, that's really handy. Otherwise, you can just wait and almost like milk the knee with your hand or with the probe, and fluid will come back to that lateral part of the knee. One thing that's very interesting, if you have a plica, so the knee may be actually divided, the suprapatellar pouch may be divided in two compartments. Here's a patient that had this plica, and here we are. So here's the probe. It's in an axial plane on the anterior part of the thigh, just above the knee. And one thing that's helpful is that you want the patient at the edge of the table, because here you can see the syringe is essentially bumping into the edge of the table. It's actually bumping into the table itself. So if you have the patient at the edge, then you can re-angulate the syringe even more. And in this case, I really needed to kind of almost point that syringe, not straight up, but higher up in order to cross to the medial part of the knee. So here I am, aspirating this lateral compartment of the knee. And notice how the needle looks like it's going down, even though in reality it's pointing up, but relative to the probe, it's actually going down. That's why this needle looks like it's pointed down on the screen. So here there's not much fluid left remaining on that lateral part. But now I'm trying to cross over to that medial part. I have to get through this plica. So I have to have the patient at the edge of the table. I have to re-angulate my syringe all the way up, and then I was able to cross over into that medial part of the suprapatellar pouch and aspirate the remaining part of that suprapatellar pouch, and then we just injected our visco supplementation. Someone can have a very large effusion, a very boggy knee, and have a lot of synovitis. So my word of advice is just try to find out where that synovitis is. Here's an older model. All this pinkish red material is synovitis, and just find the part of the knee where there is no synovitis and aspirate that part, and hopefully whatever fluid remains in the rest of the suprapatellar pouch you'll be able to get. So here's a patient with arthritis. He has a lot of synovitis, and he does have some dark signal in the proximal aspect or the cephalad aspect of that suprapatellar pouch. If you put your needle over here, even though you may think you may get a lot of fluid, it's probably just going to get clogged from all that synovitis. So really what I tried to do is just get my needle in this black zone here, the very, very proximal part of this suprapatellar pouch, which is really a couple inches proximal to the superior aspect of the patella. So avoid a confrontation when you can. Again, here we're looking at the suprapatellar pouch in an axial view. So femur, prefemoral fat pad. Here's some fluid. Now this is all the way high up on the knee. This is like, again, a couple inches above the patella. So once you find that black zone, you put your needle in there, and we were able to get maybe 50 or 60 cc's of fluid from this patient. If we put our needle where we normally would put it, right above the patella, probably wouldn't get anything, or maybe a couple of cc's. Now this is probably might be from a second syringe or maybe from the same one, but we obviously got the needle in some synovitis, because that's why this is all red. And that's more painful for the patient. So it's always better to try to avoid getting the needle tip in that synovitis. Now we're going to go through some shoulder essentials. We're going to review some anatomy. So here we can basically see pectoralis major, deltoid muscles was just removed. Pretty complicated picture here, but really we're going to just focus on the shoulder. This is the subdeltoid bursa with some peribursal fat. Now we're removing that peribursal fat. And I just wanted to show this because the subdeltoid bursa is very broad, and it covers basically just about all the rotator cuff. It goes both posterior and anterior, covers the biceps tendon, and it hangs over the greater tuberosity, and you have this dependent portion of the subdeltoid bursa. Here's the supraspinatus muscle. As that forms a tendon, as it goes distally, sometimes it can get impinged under the acromion. There's large spurs. So here's the rotator cuff now. We remove the subdeltoid bursa. So supraspinatus tendon, infraspinatus tendon, teres minor tendon. When you do your subdeltoid bursa injection, you're going to be above the rotator cuff, and you're going to be in that subdeltoid bursa. Here's a slide from Dr. John Jacobson's book. It talks about the different facets of the greater tuberosity, and there's this very round, prominent superior facet and a flattened middle facet as you go posterior, and then even more kind of posterior and inferior, you have the inferior facet where teres minor attaches. So the supraspinatus tendon attaches to both the superior and middle facet. Infraspinatus tendon attaches to the middle facet, and it kind of overlaps the supraspinatus tendon to a degree on its interior aspect. Here again, it's an image. So you have supraspinatus, infraspinatus tendons. Here's trapezius muscle, pec major muscle. And notice how the pec major tendon forms a sleeve, and that's basically over the biceps tendon. Here's the biceps tendon of the biceps brachii long head muscle. Here again is that biceps muscle, long head, and it basically goes in that interval between the supraspinatus tendon and the subscapularis tendon. Just some basic diagnostics. If you want to look at the biceps tendon, this is basically your home base view. So here is the probe in an anterior axial plane. Here's the biceps tendon. It's hyperechoic. If you toggle the probe, meaning you kind of what we call wagging the tail, or you tilt it on its basically short axis, this tendon will go in and out of view, and this is an artifact called anisotropy. So you can use this to your advantage where the tendon is bright here and black here. And this is the biceps tendon in the bicipital groove. And here's the biceps tendon in long axis. The probe is in an anterior sagittal plane, and you can see the fibers in long axis along the shaft of the humerus. Then, if you want to look at the subscapularis tendon, you have to externally rotate in order to bring that tendon out. And here you can see subscapularis tendon, this fibular structure, hyperechoic, attaching on that lesser tuberosity, deltoid muscle. I call this the subdeltoid fascia, and the actual subdeltoid bursa is this very thin sliver here. So he does not have a subdeltoid bursitis. This is looking at the subscapularis tendon in long axis. Now I'm going to look at the subscapularis tendon in short axis. Here is the probe. It's in an anterior sagittal plane. So here, the probe in this position, you can look at the biceps tendon in long axis, but now you're 90 degrees or perpendicular to the subscapularis tendon. So you're actually looking at the subscapularis tendon in short axis. So here's this tendon in cross section. These little dark hypoechoic strands is actually muscle from the subscapularis muscle that interdigitates with the tendon as it goes distally. And every tendon on the rotator cuff has its own little characteristics, and for some reason the subscapularis muscle seems to go more distal, it seems, than the other muscles of the rotator cuff. Here's the rotator cuff interval, so we're looking at the biceps tendon in short axis or cross section. Here's the subscapularis tendon. Here's the supraspinatus tendon. Now we're going to jump to the supraspinatus tendon. Most of it is hidden underneath the acromion if you just have the patient lying or standing or sitting with the arm at the side. So what you really need to do, I'm going to skip over some of these anatomy, is to internally rotate the arm. This is the crass position where you're kind of maximally internally rotating the arm. So now the supraspinatus tendon is brought anteriorly, and you can see basically almost all that supraspinatus tendon, which you can see here. The problem is this is uncomfortable and people are seeing you for shoulder pain. So this position is not really very realistic, and you also lose the rotator cuff interval in this position. So what people have done, and we do, is a modified crass. So we're not maximally internally rotating. So you have the elbow pointed back, hand on the hip, and this will give a pretty good view of the supraspinatus tendon. So here's the supraspinatus tendon attaching on that superior facet of the greater tuberosity. Notice how round and prominent it is. This is the very anterior aspect of the supraspinatus tendon, so this is probably the most common place where the supraspinatus tendon is torn. And it's also tricky because the fibers are kind of going in a convex orientation, so they're diving down towards that facet, and you can get anisotropy here, which can be tricky because you don't want to call anisotropy or a black signal a tear. Actually, the first thing you want to do is find the biceps tendon, because you know that's the interval. So then you go posterior a little bit and you'll see this. If you go more posterior, you see that flattened facet of the middle facet, which you can see here. Deltoid muscle. Here is actually the subdeltoid fascia, and this little sliver here is actually the subdeltoid bursa. So it can be pretty tricky. Here we're looking at the subdeltoid bursa. Basically, this is almost like an isoechoic bursa. Here you can see a little sliver right here. And this is what I was talking about before. The fibers actually, this looks like a gap or a tear in the tendon, but this is just artifact or anisotropy because the probe isn't perpendicular to the fibers. And now in this case, you would heel toe your probe, or you would kind of like tilt it in a seesaw type direction along its long axis, and then you can get rid of this black signal and it will brighten up the tendon. This is again one of the challenging things with ultrasound. Here's the rotator cuff interval, supraspinatus tendon, biceps. This is with anisotropy, and this is when you toggle the probe and you can see those tendons nicely. Here is, again, biceps tendon, supraspinatus. This is going from medial all the way to lateral. Here are the different cuts in a short axis plane. And eventually here, you're just basically at the greater tuberosity. Infraspinatus tendon. So again, teres minor is inferior, infraspinatus is up. Here's infraspinatus, teres minor tendons. And it's basically discussed that infraspinatus is about twice as big as teres minor. You could usually make out a little septum between those two muscles. And as you go distally towards the greater tuberosity, you can see how those tendons merge with each other. Here's the infraspinatus tendon and long axis. It's a central tendon, so you have muscle, tendon, muscle. Here's the deltoid muscle, and here's the tendon inserting on the middle facet of the greater tuberosity. Here's a pretty nice view, hard to get. I don't think many machines can do this, but here's scapula spine, infraspinatus, teres minor, supraspinatus muscle. Here's a model of the subacromial injection. So we just got rid of pec major and deltoid muscle. Here's that subdeltoid bursa. Usually I have patients lying supine. And essentially we just go right into the bursa. We're not really going subacromial, we're just going into the bursa. It almost looks like a intramuscular injection when you're actually doing this. So let's see what that looks like. Here is patient. One thing I didn't mention is when you're doing some of these procedures, you want to use sterile probe cover, sterile gel. It's good to drape the patient because look how close the needle is to the probe. Anytime that needle is close to the probe, you want to have everything done sterilely in case your probe will touch the needle and it will therefore contaminate the needle. And certainly going from patient to patient, that's not something you want to do. So here I'm using a 25 gauge needle. It's a very shallow injection. And essentially you're trying to get that needle underneath this subdeltoid fascia over the supraspinatus tendon. And here's that needle tip. And as you inject, you can see that tip even better and better as that dark fluid essentially surrounds that needle tip. You can even advance the needle further medially and almost do like a hydrodissection. Sometimes you may get adhesions between the subdeltoid fascia and the actual supraspinatus tendon. This can help break it up mechanically. So that is really all there is to it. The patient is lying supine. This is an in-plane approach as the probe is parallel to the needle. Here's another case. Here's a nice reverberation artifact of the needle. So here she is, she's supine. Here's my probe. You can see I have about 3 cc's of fluid, so mostly saline mixed with a little bit of cortisone. Here's my needle coming in. She has a little bit of calcium here, but she didn't present like a calcific tendonitis. I'm trying to just get in this little sliver here. Subdeltoid fascia, deltoid muscle. You can see that initial flash. And then as you inject, you can see how you separate those two tissue planes. So you're separating the deltoid muscle from the supraspinatus tendon, and you're really getting underneath that subdeltoid fascia is what I call it, that thick bright line. That's the key, is to get underneath that, and then you're in the subdeltoid bursa. Here's another injection, just to show you. Just the subdeltoid bursa injection is going to be your most common injection. This lady actually, she has an intrasubstance tear. You can see this kind of dark hypo or anechoic signal within the tendon. Here it is again. This is more of an isoechoic bursitis. Here's deltoid muscle, subdeltoid fascia. Here's my needle coming in. Here we're going to just again go through some of the anatomy. Deltoid muscle, supraspinatus muscle, infraspinatus muscle, teres minor, humeral shaft. We're making the deltoid translucent. Here's this broad subdeltoid bursa. Probe, needle. This is an in-plane approach. And essentially, you just want to get your needle into that bursa. Again, you're not really underneath the acromion, and here's you're continuing with the injection. All right, so now I'm going to go over glenohumeral injection. If you don't use ultrasound, you can just go direct approach in the back of the shoulder. You feel the posterior lateral acromion, and you go about an inch or a centimeter down and a centimeter over. You feel that soft spot. You aim towards the coracoid process. So this is the way you do it blindly. Here you're using ultrasound in an out-of-plane approach. So you don't see the needle, but you will see tissue move and you can get a sense where your needle is. And then you advance the needle very slowly until you see some injectate fill that actual glenohumeral space. So a lot of the work for this injection is pushing on the skin with that iodine swab and getting a sense where your needle is gonna head. So here's this patient, humeral head, glenoid. She has a little bit of an effusion, which makes life easy for you. Here's that infraspinatus tendon. So the structures you have to go through: subcutaneous fat, deltoid muscle, infraspinatus tendon, a little bit of capsule here, and then into this dark zone. So you're just gonna go straight in with your needle. You can actually use a 1.5 inch needle, and that should be adequate in order to reach this posterior recess in most patients. What does this look like? So here, usually I prefer to go above the probe, but I think in this case I'm going below. But here we're going through the deltoid muscle. Now we're making that muscle translucent. Next structure we're going through is the infraspinatus tendon. We're jiggling our needle because we really don't see the needle, but we can see tissue move as you jiggle it. And next structure you're going through is the capsule. You can see how close you are to the labrum here, and then you inject. So here I am, I'm marking where I think the midline is. And here I made multiple marks. I think it's better to make one mark and kind of know where you want to go relative to that mark. Here I am pushing with my swab. It looks like I might be a little bit touch medial, so I probably want to go a little bit more lateral. Here it looks like I'm pretty much centered, or maybe not. So again, much of the work, like any injection, is the prep work. So you don't want to figure things out after the needle is in the patient. You want to try to figure things out before you put the needle in the patient. So here I am pushing. This looks pretty right on top of that glenohumeral articulation. And this is where we're going to want to go. Some ethylene chloride spray. And here we are, we're going in, kind of just aiming towards that coracoid the same way we would do it blindly. And here I'm putting the probe above the needle. I think I probably recommend putting the probe below the needle, but either way works. And here you can see the tissue is jiggling or moving, you're jiggling the needle, and here you can kind of make out where the tip may be. Now I would recommend using saline because again, you don't see the tip. In this case, I didn't. Generally speaking, it would be good to use saline. Here we're starting the injection. There's some air that's bright and hyperechoic, and you can see how that's filling up the posterior recess. So this is really ultrasound guidance to a degree, but more so confirmation because you don't really see the needle going into the shoulder. So here's a glenohumeral injection. We're going to go long access to the needle, 74-year-old male with severe glenohumeral osteoarthritis, which you can see here. Here we're going in with an 18 gauge, 3.5 inch needle. You don't need 3.5 inch, but we use that in this case. You probably get away with a 2.5 inch, but notice how there's nothing hooked onto the hub here because you want to keep that stylet in. Here's the patient's ear, face. So this is posterior. So we're going from basically lateral, kind of anterior to medial posterior. This is an in-plane approach. Here's the needle going in. We're going basically through the deltoid muscle, through the subdeltoid fascia. And now here's the tip going through the infraspinatus tendon. And we want to make sure that tip is underneath the infraspinatus tendon. And we're essentially aiming for the bare area of the posterior aspect of the proximal humerus, which is between the humeral head and the greater tuberosity. Here we're taking out our stylet. And then we're putting on viscosupplementation. We see that initial hyperechoic flash that contours the underbelly of the infraspinatus tendon, and that essentially confirms that we're in the glenohumeral space. Here's that bare area, and you really want to just aim towards that, airing towards the side of going towards the humeral head, because if you go too lateral, you'll be injecting the insertion of the infraspinatus tendon, which would be essentially an intratendinous injection. So here it is again. That bright hyperechoic signal is air in the injectate. Here's this dark signal, which is essentially the injectate, which is pushing up on the underbelly of the infraspinatus tendon. And here it's spreading medially and laterally to a degree, but it stops at the insertion of the infraspinatus tendon on the middle facet of the greater tuberosity. And this is the most preferred way, in my opinion, of how to do a glenohumeral injection, because you can see the needle, you're aiming towards the bare area, which is just bone. So if you do hit it, you're just going to nick bone and you won't injure any articular cartilage and you won't injure the labrum. Here's another case of a glenohumeral injection. Unfortunately, we don't have the actual procedure recorded, but the actual ultrasound image is pretty nice. You can see a nice view of that infraspinatus tendon here. Here's the deltoid muscle. So you can see a glimpse of the needle going in, and we're just again trying to get underneath that infraspinatus tendon. And here's this bare area of the posterior proximal humerus. Here's the humeral head. This patient does have a moderate fusion within the posterior recess. Here's the actual needle tip. So this is really what you want to visualize on ultrasound, because that's where all the action is at the tip of the needle. And here you can see some bright hyperechoic air in the injectate filling up this posterior recess, and that confirms that you're within the glenohumeral joint. Here again, you can see it contouring the humeral head. Here's just a model of this procedure. Here's the infraspinatus tendon, needle in-plane approach. And we're basically going through first deltoid muscle, which you don't see here, and then we're going through the infraspinatus tendon and capsule and into the joint. Acromioclavicular joint, not nearly as common, but pretty straightforward injection. Here's a case where I initially went out of plane, so I didn't really see my needle, and I wasn't satisfied. I thought maybe the needle drifted a little bit superficially as I was injecting. So then I actually changed my approach during the actual procedure itself. I didn't stick the patient twice, but I pulled back on the needle and rotated the probe, and then I was able to go in plane. So here's the acromion, here's the clavicle. This is the disc that sits between those two structures. And you just really want to get your needle underneath the capsule. You don't really want to squeeze the needle between the acromion and the clavicle, because you'll ultimately wind up injuring that disc or irritating the patient. So here we are going out of plane, which is basically trying to get the needle under the capsule. And then we kind of rotated the probe and rotated the needle, and we were in plane. So let's see how that looks. So here's this space, essentially, the capsule kind of bulges up, it forms a little bit of a convexity. I'm pushing with my iodine swab. I'm trying to line up this line, which represents the middle of the screen. So I try to line up this line with the middle part of the screen, and then I push with my probe, and I can assess where my needle is going to go. Here it looks like I'm a little bit too lateral. You can see some tissue moving with this needle tip, so that essentially clues me in to kind of re-angulate, pull back on the needle, and try to go a little bit more medial. So here's my needle tip now. Looks like I'm in, and then I just started with the injection. You can see this bright hyperechoic air, which is kind of contouring the underbelly of the capsule. Here I see some more air, so this really confirms that I'm in, but I think I pulled back a little bit on the needle, and then it looks like some of it is going superficial. So then I decided to pull back on the needle and rotate my probe. Again, not the recommended way of doing things, but that's what happened during this case. And now I'm actually in plane. Here's my needle. Again, this is the capsule. Here's the space. Here's the acromion. So my needle tip is right here above the acromion. And above the clavicle, just in the middle of this whole dark zone, which is underneath the capsule. So that confirms that I'm in the space. And then I proceeded with the injection. And you can see this bright hyperechoic signal, which is air in the injectate, and that will trickle down into the joint. And basically, that's all you really need to do for this procedure. I want to thank you for watching this video. I hope that some of these injections and procedures can kind of add to your armamentarium as far as injections that you can do. And again, the knee injection, the suprapatellar injection, the subacromial injection, if you can just learn those two injections, I think that will cover probably 90% of what you really need to do, and it covers most of what we need to do here in an orthopedic practice. So thank you again for watching, and hope you found it helpful. And if you'd like to see these videos in more detail and other videos regarding musculoskeletal ultrasound, you can visit my YouTube channel at Dr. Scott Weiss, or you can also visit www.probeultrasound.com, and that is essentially a pretty well organized video library of cases that I've done over the years. Thank you again.